copper. Um, and this is under the Copper Project implemented by the Activist Coalition on TB Asia Pacific, hosted by APCASO, and the Africa Coalition on Tuberculosis, supported by the Global Fund. This webinar is co-hosted by the Regional Learning Hub of Anglophone Africa. So I'm RJ Nagit. I'm the current Knowledge Hub facilitator for the Learning Exchange sessions. So just to start first, I'd like to run through the webinar guidelines for today. So as you can see, the session is being recorded. So this will be shared on our YouTube platform so that those who will not be able to join can view the recording. I also ask everyone to change their Zoom name to the following format. So you can use your name, you can add your pronouns if you're comfortable, and also the organization that you're affiliated with. And if you're not speaking, kindly mute your mic so that we can hear from the speaker clearly. And if you're comfortable, you can also turn on your cameras. Our platform also has emojis, also have a raise hands function, so you can maximize those. And if you have questions, or if you want to add to the discussion while the session is ongoing, you can utilize the Q&A function as well as the chat function. So you can also add some comments, insights, or if there are technical difficulties from your end, you can also use that mechanism. So the session will be conducted in English and in French. And of course, we want to make sure that we have a very fruitful and lively discussion. So let's make this a safer space for everyone. And as always, you're very open to ask questions during and even after the session. Let's all continue to learn and let's share our insights afterwards. So just to start, I'd like to start this short activity. So I invite everyone to go to Mentimeter. So if you're in your phones, you can scan this QR code, or you can also click the link. So we can share the link on the chat so that we can participate in our short activity before we officially start. So the code is 37103420. So you can enter that once you enter the link or the QR code. And then I'd like to ask Mook to screen share for the results of our. So yeah, so this is our first question. So once you enter, you can type in your answer to this question. What country are you calling from? Okay, so we have people from Switzerland, South Africa, United Kingdom, Philippines, South Africa, Thailand, Ghana with a flag. Also, I see some people using the chat function. So if you won't be able to like enter the Mentimeter, it's fine. You can also type in your you can type in your answers in the chat. So in the chat, we have our colleagues from Cameroon, Kenya, Eswatini, Burkina Faso, more people from Cameroon and Kenya, South Africa. Okay, so all over the world, basically, from Europe, Africa, Southeast Asia, mainly. So I guess we can proceed to the next question. Okay, so some of you might have attended the first lessons. It was an introduction to pandemic preparedness and response. If you would recall, our speaker was Agre Aluso. And he mentioned some very important topics about pandemic preparedness and response. So would you have any takeaways, main takeaways? It can be a word, a phrase, some things that you recall from our first session. So I think participants are still typing. Okay, so I know some of you might have not attended, so it might not be applicable. Yes, Agri talked a lot about the important role of communities in PPPR. We need to be better prepared for future health shocks and have communities at the center. That's very correct. And how do we define pandemics? Though it's a very political topic as well. And then we also talked about when to declare a public health emergency of international concern, the need for more advocacy. That's also very correct, especially at the community level, I guess. Anything else? Okay, so if not, later I'll be sharing with you the link to the lessons one so that those who have missed it can view it again. So we also talked about community engagement, advocacy, and PPR. Thank you. And we go to the last question. So now the situation on Mpox is currently developing, right? So there are increasing cases of Mpox in different parts of the globe now. So any term or what are your feelings about this situation? Okay. So most people said they're worried. Some are disappointed, definitely. Things could have been better, I would say. One of you mentioned uninformed. Some are annoyed again because it's been a recurring issue already. Panicked, but hopefully, and also one of you mentioned uninformed, but hopefully after these sessions, it would allow us to be more empowered in terms of addressing those situations. Vaccine devastating. Yeah, another one. Yes. Worried also. But I think one of the things that I'd like to also highlight here is galvanized. Because when we talk about like working with communities, I think it's important that we get them on board, galvanize everyone to take action, and also be proactive in terms of addressing this, because it's not enough that we're just reactive on these kinds of things, right? Okay. Thank you for sharing your insights regarding Mpox, as well as your key takeaways from the previous session. So now let's proceed to our topic for today. Oh, before that, I'd like to introduce Lessons again. So Lessons is a series of webinars organized by the Activists Coalition on TB Asia Pacific, which started during the Community Engagement and Leadership in Epidemic Governance Response Initiative of the Global Fund. And it continued on into this project. So the overall goal of Lessons is to equip participants with knowledge on pandemic preparedness and response through lectures from resource persons and knowledge exchange activities with country implementers. So these are the different learning objectives of Lessons. So we want to strengthen the capacity of civil society to advocate for PPR and participate in health governance in their country. We want to gain insights from local experiences of CSOs in implementing PPR initiatives that can inform regional and global strategies and policies. And we also want to provide a space for reflection on issues concerning PPR. And lastly, we want to share information on global PPR-related policies and strategies that affect country-level PPR processes. So as I mentioned earlier, this is the recording of the first lessons, and you can like and share and follow Apcaso's YouTube page so that you can view the succeeding recordings. So as similar to our first webinar, you can get a certificate of completion by attending the webinar, participating in the discussion in our WhatsApp community group, and accomplishing the evaluation form, which will be presented to you at the end of the session. So now, before we go to our main topic for today, I'd like to invite Rachel to introduce the Copper Community Engagement Program. Rachel, over to you.
Thank you very much, RJ. My name is Rachel Otu Amponta, and I'm the project coordinator for Copper. for the African countries. So I'd like to give you a brief background before I delve into my presentation on copper. So by way of background, copper is the second phase of implementation on communities in pandemic preparedness and response. The first phase of this program was called the Community Engagement and Leadership in Pandemic Governance, CELG. Now, this project was birthed as a result of the impact of COVID-19 across different populations, which greatly underscored most of the work at the country level in terms of integrating health equity, human rights, gender equality into the HIV, TB, malaria programs. And so two COVID-19 response mechanism surveys, C19RM surveys that were conducted in 2021 and 2022 showed that there was lack of engagement of the last mile population in the C19RM response, who experienced increased vulnerabilities and risk. And so the entirety of the first phase was basically focused on the identification and building of capacities of the last mile population in specific countries in Asia Pacific and Africa, so they could participate in the TB response as an entry to participate in pandemic governance and response at the country level. And so we worked with 5 countries in Africa. Nigeria worked with nomads and internally displaced people. Cameroon worked with internally displaced people. Kenya worked with people with disability. Sierra Leone worked with people with disability and internally displaced people. Indonesia worked with former prisoners. Mozambique worked with minors, ex-minors. Philippines worked with tricycle operators and drivers association, and Cambodia worked with internal migrants. And so based on the assessment that were conducted, the country partners developed an engagement plan, which they implemented. And so basically the second phase is COPA, where we continue to work on the first phase, but this time around, we are expanding to cover HIV, malaria, and other future pandemics. And so some of the lessons that came out from the first phase was that there's the need for protocols to ensure diversity of last mile population needs to be defined. And so what this basically means is that, for example, Kenya worked with people with disability, and they realized that usually people with disabilities needs are not put into consideration before initiation of project. And so this was one of the lessons that came out. And secondly, the second lesson was multi-stakeholder partnership and community CSO coalition needs to be established. This particular lesson or recommendation is one of the activities that will be implemented under COPPA. And then the third lesson that came out was that government and relevant stakeholders, including relevant civil society, need to consider the time of work of the last mile population. For example, in Cambodia, most people who are considered last mile population were not willing to leave their place of work and engage. And so there was the need to look at the time of work and then when to engage them. And then the fourth lesson that came up was PPRC training, which is also one of the core lessons or core trainings or core activities that will be implemented under COPPA. Next slide, please. And so what is the aim of COPPA? The aim of COPPA is under 3 thematic headings, basically to build knowledge and capacity of communities on PPR. And in this way, we are ensuring that community have access to accurate and timely information, tools, and resources on PPR. And secondly, to strengthen the capacity of communities at the national level and facilitate their engagement in country-level PPR decision-making fora. Secondly, COPPA aims to strengthen meaningful community engagement in PPR governance, basically by supporting meaningful community engagement in PPR governance, implementation, and oversight, including everything that happens at the national level in terms of PPR platforms. So we are looking at the CCM, the JEEs, and then the SPA platform. And lastly, to support coordination, evidence generation, and use, basically to enhance coordination and networking, both within the traditional HIV, TB, malaria communities and in partnership with other PPR actors. Next slide. And so the COPPA implementation is in two folds. Regionally, through the COPPA Knowledge Hub, which we are on currently, which includes promotion of PPR-related knowledge, capacity building opportunities, and learning exchange through webinars, and then through the websites. And also regionally, we have developed training toolkits which are to be used at the country level, community level, in ensuring that PPR literacy is known or done across board. And also, regionally, we are developing a compendium which will be made up of community kits of various thematic areas. So the compendium will be made up of community guides on the various topics: PPR 101, Pandemic Accord 101, Climate Justice, and PPR, Gender Equality, Human Rights, and PPR, Community Engagement, and PPR, that is learning from HIV, TB, and malaria, antimicrobial resistance, and PPR. And then also we'll have 3 additional community guides from COPPA CLM, where they will look at they'll focus on key intersectionalities on CLM and PPR. And so at the country level of implementation, we are working in 8 countries, 5 in Africa, and then 3 in Asia Pacific. So we are looking at Cambodia, Cameroon, Kenya, Indonesia, Liberia, Nigeria, the Philippines, and Sierra Leone. This slide. And so activities being implemented at the country level include training workshops to build the knowledge and capacities of communities on PPR for effective in-country level engagement on PPR decision, and then the development of advocacy agenda, strengthening existing coalition by meeting quarterly, and of course, regional and national advocacy meetings with stakeholders, basically for inclusion of the communities on and in the PPR planning and implementation. Next slide. Oh, okay. So basically that's what COPPA is about. But then I think I forgot to mention that for COPPA, we have the COPPA CE, which is the community engagement, and then the COPPA CLM, which is COPPA community-led monitoring. There's a whole session on COPPA CLM, which will be held in January. And so that's all, and I'll hand over to RJ. Thank you.
Thank you, Rachel, for that very comprehensive discussion on copper, and hopefully we get to learn more about the other activities later on in our succeeding sessions. So now we go to the meat of our webinar today. So I'm very pleased to introduce our speaker. So Fifa has over 13 years of experience working in global health, focused on strategic engagement, the amplification of global South expertise in GHIs, and qualitative research. As a principal consultant at Matahari, she leads a team of 5 consultants and has led and coordinated projects to develop the strategy for the Global Coalition of TB Activists, a final evaluation on the impact of COVID-19 on HIV and TB services in Eastern Europe and Central Asia, and to document lessons learned from pediatric TB advocacy in 8 countries across Africa and Asia for the Elizabeth Glaser Pediatric AIDS Foundation, among other public health related projects. Through the acute phase of the COVID-19 pandemic, she was the NGO representative on the WHO Access to COVID-19 Tools Accelerator, or ACT Accelerator. And formerly, she was board member for NGOs at Unit Aid, working on equitable access to HIV, TB, malaria, and cervical cancer tools. So her role, her CSO role involves political influencing and data analysis across the pandemic preparedness spectrum, from vaccine development and access to mRNA hub advocacy to rapid self-test access and resource mobilization for community health worker salary. So quite a lot that she's working on. And she's also part of the technical working group for the WHO framework for research, development, and innovation for health security preparedness. Her analysis and insights have been included in pieces in various media. So some of the media that she wrote for are the New York Times, The Guardian, Devex, the Hindu Business Times, among others. So her work experience has taken her to early infant diagnosis facilities in rural Mozambique, to villages receiving HIV self-testing kits in Mazowe, Zimbabwe, and to the World Health Summit in Berlin. So from very local to a very international platform that she's engaging in. Based on her professional academic qualifications, she received her PhD in law from the University of Leeds, her master in health law from the University of Sydney, and a Bachelor of Laws from the University of London. So without further ado, I'd like to introduce to you our speaker, Dr. Fifa Rahman. Let's give her a round of applause, please. Over to you, Fifa.
Thanks very much, RJ. So I'm going to share my screen and go into a little bit of a 101 on the pandemic accord. And one of the things that is probably most pertinent in the bio is that I was the pandemic negotiations consultant for Africa CDC. That's my most recent role, and that's where most of my knowledge on the pandemic accord has kind of cultivated from. I'll talk a little bit about how my role at Africa CDC has informed the presentation today. But essentially, we're looking at what is the pandemic accord, who are the key actors, and what are the key sticking points or the key disagreements that the Global South generally has against the Global North. So first, an overview of the contents. What is it? Is it a framework convention? Is it a treaty? Is it a regulation? And how is it enforceable? The second thing we'll go into is who the key actors are, the Intergovernmental Negotiation Body, who the Bureau is, who the Africa Group is, who the Group of Equity is, and the EU and the US and what their positions are. And then we have what are the key issues. We've got pathogen access and benefit sharing, One Health, R&D, IP, and governance. There are, of course, other issues in the pandemic accord, but we will go through kind of the most controversial ones. And then we go into a question and discussion on what else you need to know, whether I explained it clearly. It is going to be quite technical. So I don't expect you to understand everything on the first go. That's why my email is there, and you can contact me at any time if you have any questions. So let's go into the pandemic agreement. So what is it? So it's intended to be an international legal instrument that member states can sign onto and or ratify. So just because a country signed it doesn't mean they would ratify it. So what does ratification mean? Ratification is important, and it's a process essentially by which a state declares its consent to be bound by a treaty. And how does a state consent to be bound by a treaty? It usually goes through each country's legislative organs. So it could be a parliament in some countries, or a Congress, or in Mexico, for example, and some other Latin American countries, it would be a Cámara de Diputados. So now, it's important for me to explain this because of a lot of disinformation that's out there about the pandemic treaty, especially in Western media. There's a lot of nutcases who have said, oh, the WHO will be able to declare a lockdown at any time. No, that's incorrect. The pandemic agreement first of all, doesn't have provisions about lockdown in it. And we'll go through its contents, but also anything that is in the pandemic accord will only be applicable when the local legislative body ratifies it and creates local laws to implement it, right? So there is a level of national approval to what is in the treaty. So all this crazy stuff that's coming out of the United States and the UK, and I'll show you an example of one of these crazy articles that really isn't bound, isn't based in any real legal knowledge. Okay, so the first thing that I want to talk to you about is what is the agreement going to be? So the character of a pandemic agreement is it's an international treaty, but treaties are different from regulations. So this is important to know for several reasons. So the international health regulations, for example, is a form of regulation. And regulations are generally less, they're less prominent. They are less likely to generate a lot of political will because regulations don't have to be debated in Parliament, whereas treaties do. So when the debates happen in Parliament, usually that attracts a lot of media attention, which increases the political will. So at the start of the discussions of the pandemic agreement, and in fact, even this morning, so there are discussions going on this morning that you can actually watch on the INB website. But essentially, there's still discussions about whether this agreement should be a treaty or a regulation. And this matters for so many reasons. So right now, there's a lot of people in that room saying that they want it to be a treaty rather than a regulation. So they want it to go through their local legislation, legislative bodies, and they want to be able to debate it at the national level as well. And they want it to be legally binding. So a regulation would, there are some countries that prefer a regulation format for the pandemic agreement, like the United States. Now, there's historical reasons for this. It's because the United States has such a powerful lobby that is, how do I say this in a politically correct way? That is promoting misinformation, essentially. So the United States actually has not signed any treaties for decades. But with regulations, it doesn't need to go through Congress. And when it doesn't have to go through Congress, they don't have the mass Republican misinformation lobbyists blocking it. So there are some countries like the United States that want regulations. But as advising the Africa group, especially in my role, we think that it should be a treaty because this way it will receive more political attention. So there are lots of different types of treaties, and a framework convention is one of them. So the most famous framework convention is, of course, the Framework Convention on Tobacco Control. And the Framework Convention generally is a treaty that has some general obligations with more detailed rules later. So you create a two-step procedure. So there could be a main agreement, and then you decide on certain things later. Now, the reason why they are trying to go towards a framework convention as opposed to just being a normal treaty with all the rules in. So a framework convention will not have some of the rules in, and it will develop some of the rules later. Okay, so those are the two differences. And the reason why this pandemic agreement is sort of going towards a framework convention is because there are many, many, many disagreements between the global south and the global north. And these disagreements are very fraught, and you could say that some of them are deadlocked. So we can discuss why it's going towards a framework convention later. So I know this is all nerdy stuff, but I think it's important to say because I'm going to refer back to it later, and you're going to need to know it. Okay. And I described a little bit about regulations, and WHO regulations are supposed to be the first line of defense against health emergencies. And generally, regulations pertain to competencies, nomenclature, temporary recommendations, and prevention. So a treaty, you want a treaty to be more powerful, essentially. And regulations aren't very powerful. They don't get discussed at national level, really. They only get discussed at WHO level. So essentially what we want this to be is to be a treaty, right? And whenever you hear articles talking about whether we want this to be under Article 19 or Article 21 of the WHO Constitution, Essentially what that means is 21 is regulations and 19 is treaty. So whatever you do when you're advocating at the national level, you want it to be an Article 19 treaty. So, and sorry if I'm repeating myself, but if it's a treaty, basically it goes through your Congress or your Parliament or your Cámara de Diputados. So, this is an excerpt from a report I wrote for Wits University on the Pandemic Accord, and this is from a legal expert on the character of treaties. So what do you need a pandemic accord for if issues like pandemic pathogen access and benefit sharing, which I'll go through in a bit, are addressed through amendments in the IHR. So there is an approach by negotiators now to put certain topics in both agreements, but of course, this was before the IHR was finalized. So the IHR is now finalized, and we now need to finalize whatever it is in the pandemic accord. So he says that treaties are important signals of priority, both globally and nationally, and an accord or an agreement or a treaty can help advance issues where universal adherence will take time. So what does that mean? Where there's high levels of disagreement on the content and how to implement the content, treaties are better, because regulations, everybody has to agree. Everybody who's a party to WHO will automatically be signed up to the regulation. Whereas a treaty, you actually have to, your mission in Geneva actually has to go, okay, we are signing as a country. So that there's an active step there. So treaties are beneficial where there's heavy disagreement, and there can be interpretation on the national level of what that means. Okay, so on the right side, you have a snapshot from the April version of the text. And of course, as negotiation rounds go on, the text does change. So that's why I wanted to make a point about this being the April one, and you might see other versions around that don't have the same set of or the same order of issues. So this is the content of the pandemic text, accord text as it is. So there's use of terms, so that's the definitions, such as what does pandemic mean, etc. There's a section on One Health, and One Health, so that's a little deceptive because One Health is Article 4 and 5, and 4 is probably the most important one. There's a section on health and care workforces, which is relatively uncontroversial. There's Article 9 on R&D, which is quite controversial. There's technology transfer and know-how in Article 10. Article 11 was transfer technology and know-how as well, which was combined. And there's access and benefit sharing, which is the most controversial part of this pandemic accord, and I'll describe it shortly. And it doesn't just go to Article 16, there wasn't space, it goes to all the way to Articles 25, 26. But Article 21 essentially is about governance, and that's very important as well. So let's get into who the key actors are. So the INB is the Intergovernmental Negotiating Body. This is the member states. These are the countries negotiating the pandemic agreement, and they are the WHO member states. So who is in the room? And if you look at the discussion today on the INB website, you will see that they're usually represented by Geneva-based diplomats attached to each country's embassy. And some of these diplomats are seconded from the Ministry of Health and placed in the Geneva mission. So, but of course, they report back to capital as to what the discussions are, and the Ministry of Health and the Ministry of Foreign Affairs in each country are the parties that get updated on what's happening. And then you have the INB Bureau, which has co-chairs with one from the Global North, and that's France at the minute, and one from the Global South, which is South Africa, in Precious Matsoso. So the Bureau is in charge of developing the text and maintaining the transparency of discussions. So they need to promote online what the discussions are about. What they've done recently, if you follow the WHO Instagram, is they do little videos of the room in which they're negotiating and things like that. But all that stuff is predominantly, of course, for to combat the misinformation that's out there that is done in a secret bunker somewhere in Geneva, which I mean, would be very interesting. And I've attended many of these negotiations, and I can guarantee they're not in a secret bunker. But yeah, so there's a lot of work on maintaining the transparency of discussions. And then there's a secretariat, which is the WHO staff in charge of assisting the INB Bureau. And then the most important group for me, which is Africa Group plus Egypt, which is the group I advise and I provide positions for, and I do research for, which is a group of African nations agreeing positions in a common African position. And generally, the Africa Group plus Egypt has advocated for time-bound TRIPS waivers, clear benefits in pathogen access and benefit sharing, and a COP governance mechanism. So the COP is the Conference of Parties governance mechanism, which I will describe shortly. So the reason why it's Africa Group plus Egypt is because Egypt usually goes along with Algeria, Tunisia, and other North African countries. But this time, so it's a bunch of African countries which are not from North Africa plus Egypt. So Egypt is together with the Africa Group. And then there's a group of equity, which is generally Global South countries, which includes some African countries, but other countries include Philippines, Mexico, Malaysia, Colombia, and others. Okay, so let's go into some of the key issues in the pandemic accord. One Health is a major one, and One Health is contained in Articles 4 and 5. And this is a snapshot on the right of what is in Article 4, which I think is the most important part of the One Health provisions. So in Article 4.2, you can see that there are many subsections which predominantly the Global North want the Global South to do. So there's collaborative surveillance, there's water, sanitation, and hygiene, which is C is relatively uncontroversial. There's zoonotic spillover and spillback prevention. And there's laboratory biological risk management, etc. So these are very controversial for many Global South countries. And the reason why, of course, so maybe let's take a step back and talk about One Health as a concept. So as a concept, it was developed not by member states. It was developed by quadripartite. And the quadripartite is a group of UN agencies that decided the concept of One Health. So it's WHO, the Food Administration Organization, so FAO, WHO, and a couple of other agencies. And they decided One Health is a concept, which means we have to look at health from an environmental, human, and animal health standpoint, right? So the reason why this is so controversial is because of the extensiveness of the provisions. So essentially, this is a question about resources, and it's not like African countries don't support One Health. They have a lot of One Health initiatives at the national level, but whether countries, not even just in Africa, in Malaysia, in Brazil, they said collaborative, and this word has changed. This is from the April text, and the text has changed to be collaborative and interoperable surveillance. These are all big words, but it essentially means that you need to be able to surveil what's happening in animal health and environmental health and human health, and that the platform must be interoperable. So it must work the same across all the areas of health and between all the agencies involved. And it must be, it must report frequently and all that kind of stuff. And what that means is essentially that there's going to be a lot more resources diverted to surveillance when countries, not just in Africa, but also in Brazil and Malaysia and many other Global South countries, we have a lot more pressing priorities where resources need to go. And essentially, you can't expect Global South countries tomorrow to have all the staff members needed to do collaborative and interoperable surveillance, right? So essentially, there's a lot of concerns around what can countries agree to, considering the resources that they have. What are the real implications of these commitments? So one thing that I'm kind of working on is helping countries understand what is the impact of Article 4.2a, right? Collaborative interoperable surveillance. You'll have to have software that works across your Ministry of Wildlife, your Ministry of Health, Ministry of Game Parks, Ministry of Farming and Agriculture. So essentially, it's like it results in a lot of resources at the national level, and how long do we have to implement these? So this is why it's so controversial. And the global majority, which is the global south, of course, one of the questions that people are considering is whether people are really against One Health. That's not true. Lots of global south countries have One Health issues, but they're against this text because this text gives you a lot to do with limited resources. And another reason why member states are objecting to One Health in this kind of detailed manner is because of what we lawyers called lawfaring. Have countries agreed to the definition of One Health, right? It was created by UN agencies without debate. So that's a little bit of a concern. And number 3 is political economy trade-offs, right? What if we're to agree to One Health, what is the global north going to give us? Because this is a very global north agenda, right? They want us to look at surveillance across animal, human health, etc., because they don't want global south diseases to go to the global north, right? So what are they going to give us for One Health, or for agreeing to One Health, right? So that is a trade-off that we need to consider. So I'm rushing a little bit because it's quite technical, but we need to get through it. So pathogen access and benefit sharing is the most controversial thing that Global South and Global North disagree on. So PABS, as we say for short, is in Article 12, and it basically says that if a pathogen originates from, say, a Global South country, that must receive benefits at the same time. So what does that mean? Is that if a vaccine is created from a pandemic pathogen, taken from, example, Botswana, so they take it from Botswana, and they use it to make a vaccine that can essentially prevent infection or cure or a medication or whatever it is that they use the pathogen to create, they must provide benefits back to the global south. So it's not necessarily Botswana that gets it. So WHO will decide how to distribute the vaccine or medication that's created from Botswana genetic material. But essentially, there has to be benefits. Now, if you look at Article 12.3b1, it says in the event of a pandemic, there should be real-time access by WHO to 20% of the production of the pandemic-related health products. So this is of course products that have been developed from the genetic material from the global south, right? So it's 10% as a donation and 10% at affordable prices. This language has changed a little bit since then, since April. It's now 10% free of charge and 10% at not-for-profit prices. So that means WHO would still buy them from the company, but at an affordable or not-for-profit price, at a cost price, right? So the global north doesn't like these percentages. The United States and the UK want up to 10% as a donation and up to 10% affordable prices. So we are heavily against this as the Africa group because up to 10% could mean that you're donating 0.0001% of your production, right? So this is like, you know, they're behaving just the way they behaved during COVID, right? They just, you know, it's not global solidarity, right? So there's a lot of concern around the percentage of what will be donated to WHO or sold to WHO at an affordable price. And this doesn't even pertain to all products, right? This is products developed from pathogens that are registered within the PAB system. So it's essentially a database where you would upload the genetic material of the pathogen. There's also issues around the words "is hereby established." So if you look here at the PAB system is hereby established, some countries don't want it to be established automatically. So what this means is that the moment that the pandemic agreement is signed, it would establish a PAB system. And some of the global north countries don't like these words because it will establish a PAB system immediately, whereas they would prefer that a PAB system is established later through protocols. Remember, we discussed Framework Convention and how Framework Convention, you decide on some stuff in the main treaty and you decide some other stuff which you disagree on later through protocols. So this is what this is about when you talk about is hereby established, because is hereby established means the moment that it's signed, you have a PAB system, which we want as Global South. But some Global North countries, they don't want is hereby established. They want it discussed later in protocols to the Framework Convention. And then another thing is digital identifiers. So I wanted to find an easy way to talk about digital identifiers. And the easiest way to explain is Netflix. So if one of us downloads movies or streams movies on Netflix, Netflix has identifiers attached to that movie that shows that FIFA watched this movie or this series, right? So it's essentially a digital tag that shows, who's watching that movie, right? And what we want as Global South is that the pathogens and whatever products are developed from them have digital identifiers, so we know that it's PABS material. So if it comes from Botswana or Philippines or Tanzania or Peru, you would know that pathogen or that genetic material that was extracted from a Tanzanian human being or a Botswanan human being or Filipino human being has been used to develop this vaccine, right? So if it has been used to develop this vaccine, and we can track it through a digital identifier, we know that it's PABS material, and therefore the percentages donated to WHO would kick in, right? The Global North do not want digital identifiers. They keep saying it's impossible, there's no way, it's too complex. Like scientists upload so many pathogens to databases. If you put a digital identifier, it will restrict Global South research. So they make it about us, right? They say, there's no way that Global South scientists will be able to develop vaccines if they're digital identifiers, etc. Essentially, they don't want it to be traced. And if it can't be traced, there's no way we can know that the pathogen was used to develop a vaccine, right? So digital identifiers are very, very important. So, so this slide is essentially about the disinformation. So this is a Telegraph, which has about a readership of 79,000 people in the UK, but it's the rich Tories that predominantly read them. So this article created such a furore during the negotiations, which said Britain would have to hand over 20% of vaccines under the pandemic treaty. So this is incorrect, of course, because 10% is supposed to be free of charge and 10% is bought from the British company, potentially. So the British company would still make money. But essentially, when the British negotiators saw this, they got a call from the Prime Minister during the negotiations and said, we cannot agree to anything in PABS. So obviously, since the Global South wants PABS, this was a massive issue. There's also some nonsense that Global North institutions like the Leibniz Institute of Virology say, and a lot of them, these are pharma talking points, right? That traceability requirements, which are the digital identifiers, would disrupt scientist research in the Global South. So of course, I, as the advisor to Africa Group, I've done the research on whether this makes sense or not. So there's a database called the EMBL-EBI database, and this database has digital identifiers. You are able to know who uploaded the samples and who downloaded it to create a vaccine or a medicine or whatever it is, right? So in this database, you can see that over 3 million SARS-CoV-2 or COVID samples were uploaded from the UK. And then 2 million were uploaded from the Wellcome Sanger Institute. So it's not really like scientists don't stop uploading pathogens just because they're digital identifiers. It's really not a big deal. And plus the EU, even though they don't want digital identifiers, have their own guidelines that recommend tracking of data and for them to have identifiers. So there's a lot of lies that they're telling, which we have to make sure our negotiators know. So I put some examples on why traceability is possible. It's not, you know, all the pharma talking points that people are talking about doesn't make sense, really. Okay, next issue is IP. So you've got technology transfer on mutually agreed terms. What essentially does this mean is that during a pandemic, we should encourage technology transfer, or we should require technology transfer. And what that means is if there's knowledge about a particular vaccine that is needed for, say, a South African company to manufacture a cheaper version to increase access, or a Filipino country to be able to manufacture something. So any knowledge about that product can be transferred to the organization or the government that can make that product. So the key issue here is the words on mutually agreed terms. And this is what you have to look out for, because you know, non-technical people will look at it and go like, oh, mutually agreed terms sounds nice. When you mutually agree things with people, it sounds like you're friendly. The state and industry should not necessarily be friendly with each other. And you wouldn't, during a pandemic and people are dying, you would want to be able to regulate as the country, regulate the industry. So the state should decide when the transfer of technology should occur. So that, you know, one of the things, and I was speaking to some ministers earlier this year on this mutually agreed terms, and some ministers were saying, oh, I like the term mutually agreed terms. It's not a good thing. Just because it sounds good, you have to look into each legal language essentially and understand what it means. So when you mutually agree technology transfer, it means you're going to go to pharma and go, hey, pharma, would you give up some knowledge about this vaccine and give it to South African companies to make? They're never going to mutually agree. So basically, the mutually agreed terms text means that they're going to make it basically that it won't work, right? Okay, I am rushing a little bit, but I'm happy to answer any questions if it's not clear. Article 21 is very important on governance, and we got Conference of the Parties in as the governance mechanism. So what does this mean? It's essentially it's the check and balance for the treaty. So once the treaty is signed, how do you make sure that countries are keeping up to it and following up with their obligations and all of that? So the Conference of the Parties is what we want, because COPs, it's COP for short, COPs are wider than the Ministries of Health. And pandemics they're not just a Ministry of Health issue, right? If it's going to shut down your economy, shut down your trade, shut down your jobs, this is an issue for infrastructure, it's an issue for labor, it's an issue for human rights. It's a lot wider than health, right? Which is why we want it to be a Conference of the Parties. The United States, in particular, does not want a COP. The United States wants it to be a third committee, in the third committee of the World Health Assembly. Now, if you know how the World Health Assembly works in Geneva, it happens over the course of 2 weeks, and the ministers and all the important people will usually attend kind of the first committee and the first few days, and then they'll go home. Usually by the second week, it's all the junior interns and all that kind of stuff who attend. And for pandemics, you don't want something as important as pandemics. You don't want the interns. Sorry, somebody's mic is on.
Sorry, let's try to mute.
So,
Okay, sorry.
yeah, so you don't really want just the intern Yeah. Please.
Yung ganda super.
Sorry for that. I'll just mute everyone first, except for FIFA.
Okay.
Thank you.
Super. So you don't really want the interns to be attending discussions on a pandemic. I mean, the interns could attend. It'll be good, like capacity building, but you want important people there. So Tariro, you're unmuted. Do you mind muting, please? Tariro? Yeah. Okay, super. No, the person's still muted. So if we can find Tariro and mute him, that would be good. Okay, so yeah, so essentially there are different things that countries want. We want, as Africa, and when I say we, I speak about Africa Group mainly, but Africa Group wants a COP because then, you know, you can bring all sorts of other parties. You can be more civil society to a COP rather than as the World Health Assembly, which is usually mainly Ministry of Health. Some CSOs go, but it's not really very accessible, whereas a COP is more accessible. So the key is the United States, which might not even sign it if it's a treaty, are the key, you know, opposition to it being a COP. They want it to be in the third committee of WHO. So as long as pandemics are not the sole responsibility of MOH, it's the MOE and other ministries, we should have it in a COP so it has the widest possible attendance and the most diverse attendance. So I know I rushed through it and it's a lot of technical material, but let's pause for questions and discussions. And I'm happy to explain anything that maybe wasn't clear. Thanks.
Thank you, FIFA. I think everyone can agree that it was a very rich discussion and also a good backgrounder in terms of how these things are negotiated at the international level. So just to run through quickly what FIFA talked about. So at the start, she talked about the differences between a treaty and a regulation. She also went through the different key actors, the INB, the INB Bureau, also the different groups of countries working for equity. And then she also mentioned the key issues that are quite contentious currently, such as One Health, the pathogen access and benefit sharing, issues of IP and COP. So I see that there are two hands already. Maybe before we go through the ones who would like to ask, I'd like to ask the first question first. Because I know that the pandemic accord is not just it should not be taken in silos with the other pandemic related declarations. So how do you see all of these declarations fit in terms of like promoting the issue of equity?
So I guess I'm a little confused because the word declaration solely pertains to, do you mean legislation? Or because declaration is only the declaration for the public health emergency of international concern or regional concern in the case of what Africa CDC can do. So I get, can you rephrase your question? Just because, yeah, I don't know what you mean by declaration.
Or maybe we can the other legislations in terms of how they relate to the pandemic accord.
Okay, super. So the international health regulations are probably the most important ones, and those are finalized. And the international health regulations is it's more about prevention and how to prepare for a pandemic. So every country, for example, has to prepare a joint external evaluation on the state of their labs and the state of the prevention mechanism. So there's less focus on equity in the regulations. It's more about what countries can do to get their labs up to the right status and you know what prevention mechanisms they've got at the country level. So when you're looking at equity, you're going to be looking more at the pandemic accord, because it really has more of those human rights elements in it compared to the regulations. The regulations does have more kind of rights equity-based language in it now, but if you look at the text, and the text is publicly accessible, it's very much focused on what a country needs to do, including increased capacity of laboratory workers and things like that. So it is quite different. So I would probably say focus on equity in the pandemic accord.
Thank you. So let's proceed to those who are raising their hands. We go first with Lizzie, and then Leslie, and then Dr. Bedima. Is that all right? Go ahead,
Right,
Lizzie.
thank you. Sure. Hope you can hear me. So mine is a bit quick. I mean, the discussions around the pandemic accord or treaty. So a lot of CSOs and community groups literally being locked out of negotiation rooms. And we saw the fact that that was one of the reasons why we never actually got to an agreement. I just need to ask directly, what are the chances, or how do you feel being a consultant next year in May in Geneva, actually as having a pandemic accord and all agreeing, because there was a lot of back and push, not only on PABs, but also the financing model. And we saw also the Global Fund strongly come out on their stand around financing as one of the articles. So I just need to know, from your own perspective, how are they addressing the fact that communities were locked out and this is not going to happen, as we've been given a second opportunity to, just go back to the drawing board and start negotiating and discussing again. And what do you think we're going to have this treaty next year in Geneva at the WHA? Thank you.
So
Can I add to that, Fifa,
Yeah.
before you, sorry, because my question, I almost put my hand down. Sorry to interrupt you. Thank you. That was great. But I wanted to raise exactly what Lizzie's raised in terms of like the locking out of civil society and communities, but linking to that, this group, the copper community engagement and CLM partners, as well as others on the call, like what would you advise us in terms of when civil society at the global level is being locked out? How can we ensure that we're still involved, and or what should we be doing at country level if we can't access that global discussion? Is there something we should be doing with our in-country decision makers to be a better part of that? Sorry for interrupting.
No problem. So in terms of locking out of civil society, so because I've been representing, I guess, a regional organization for the past time, I don't know how much, I don't know necessarily the full story of your participation, but in general, I feel like there has been insufficient pressure upon the co-chairs and the member states. So there are some member states who are very against civil society participation. And even on the, say, Fridays when we would usually have the briefings with civil society, there was some member states, usually in Asia, and that would say, no, we don't want civil society involved. And this is where kind of we agree with the European position, because the European position is like as much transparency as possible. So I do think we need to identify those member states that are a problem and put pressure on them, but also pressure upon the co-chairs. So the co-chairs of France, and France does support transparency and inclusion of civil society, and Precious Matsoso as well, to make sure that civil society is included. Although, even last year when civil society didn't, in the end, they didn't have sessions with civil society, even in the room, when they should be civil society statements in the room. Even the co-chairs kept saying we're bound by member states, and member states couldn't agree. So I think there needs to be a more concerted targeting of member states that disagree. So yes, second question, sorry. Are we going to have an agreement next year? I think that if there's no resolution on PABs, to be honest, financing is not going to be the make and break of it. We disagree on financing, but it's not going to break the agreement. What's going to break the agreement is PABs. And if there's no PABs, there's not going to be an agreement.
Yeah, so that's a very important discussion by next year. So hopefully it does get resolved. Lizzie, is that the legacy hand or
Oh,
is
it's
it
a new one, but I've seen
new person?
Dr. Dude's hand up, so I'll just wait until he's done.
Yeah, so maybe we can go to Dr. Bedima and then some questions in the chat and then
Yes,
to
yes,
Lizzie.
yes. Can you hear me?
Yes,
Fifa,
we can hear you.
I have a few, I don't know, it's from a philosophical point. I've been struggling to appreciate how a pathogen, a country can claim ownership to a pathogen as a resource. Even though I come from Ghana, I'm coming from the global south, I understand the benefits. But I've been struggling to understand how a disease-causing pathogen, a country can claim ownership to it. What makes it, what ties it to that particular country as a pathogen that can fly across the Atlantic and go everywhere? That is one. So the PAP system, as much as I understand how it's going to benefit the global south, I'm struggling to understand the philosophy, even though I am aware of the Nagoya Protocol and all that, but I'm struggling to understand how a country can say, well, a disease-causing virus is my own. Okay, so maybe you may help me a bit. Then the second one is the IHR and its implementation. And because there are regulations, I don't see it, the amended version, I don't see how it's going to deal with how countries did not respect them. There were no implementation mechanisms in countries, and how is going to be sure that this time the regulations, because countries will not debate it in parliament, and our legislatures don't even know what these regulations are about until there is an outbreak of a disease. And there is only the Ministry of Health and one or two officials who are running around trying to explain what the international law is. So I've been asking whether they knew the amended regulations should still have a way where it can be domesticated in local law so that many more people will get to know what these things are. Otherwise, if it's assented to and they are just regulations and they are lying at the WHO, it's only few people, and the people only get to know of it when there's an outbreak. So these are just my few. They are not really questions, but I just want you to share your thoughts on them.
So one question on digital identifiers, and second is how do we disseminate this information?
How do we implement them actually on the ground? Yes, on the ground.
So I'll respond. So that's not actually a digital identifiers question. That's a question about ownership. So ownership of pathogens. So so it's less about the ownership of the pathogen, rather than the goodwill of the scientist who detected that pathogen to share it with the world, to benefit the world. And sharing it with the world generally means uploading it to one of these well-known databases, right?
Yes,
So it's about the goodwill of that scientist in developing that. And that was done, for example, by Botswana with Omicron, right? Botswana was the one that identified Omicron first. And what did Botswana get in return? So this is about reciprocal benefits. So Botswana, in its goodwill, shared Omicron with the world, and in turn did not only not get enough vaccines for its population, but it got punished by people banning travel from Botswana, right?
Yes.
So that is not reciprocal benefits. So we need, as the global south and as the African continent, to make sure that not only are we not punished for the goodwill of sharing pathogens that can be used to develop vaccines, and vaccines were developed from those Omicron pathogens, right? They were Omicron specific vaccines, right? And so that in future pandemics, when the goodwill of Botswanan or Filipino or Malaysian or Peruvian scientists is not misused, essentially, that they've shared this pathogen with the world. You can't punish us for doing that, and you should also provide the vaccines that you have developed from it. It's less about ownership and more about goodwill. On amended IHR and enforcement, so this is why financing is such a big deal, but I feel like a lot of negotiators have kind of given up on financing and want to focus on PABs and other things. But one of the biggest problems that we were discussing, because Germany, for example, has not done joint external evaluation that's supposed to be done. Every country is supposed to be doing a JEE under the IHR, right? Germany has not for years and years and years, right? And a lot of, like the US and the UK, there were a lot more deaths in these countries, right? So they should be caring about the pandemic preparedness and response. But the fact is, enforcement is going to be tough without financing. So without financing for WHO folks to fly into a country and go, "Where's your JEE? Where's all these?" So I agree with you on it that enforcement is going to be tough, but that, in terms of your advocacy at the national level, in terms of converting that into legislation, it's very rare that regulations are converted into domestic legislation. It's more common for a treaty to be converted into domestic legislation, which is why the treaty has to be focused on. I hope that answers your question.
That's okay. That's okay. That's fine.
All right, thank you. So now we go to the questions on the chat. So Jared was asking regarding the current discussions applicability in the current MPOX situation, or are there any new learnings that we can take and consider in the next round of discussions?
So so there's a journalist who just got in touch with me about whether the pandemic accord, as the way it's written, would benefit the current MPOX situation. So obviously the treaty it's not retrospective, it hasn't been signed, so it doesn't apply at the minute in the MPOX situation. But in improving the pandemic accord, one of the things that we have to think about is whether it would benefit the MPOX situation at all. And as without PABs, it wouldn't, because you cannot compel the global north to give the mpox vaccines. We see all the injustice that's already happening now. Canada has 4 times the vaccine supply that is needed for their country. That kind of thing. It's going to happen again and again. So this is why kind of PABs is so important. It's to bind the global north to certain provisions that require transmission of vaccines and ensure those agreements are in place. So right now, mpox donations are happening out of the goodwill of the global north, which often isn't good unless there's some political will. So without PABs, if we don't get PABs in the pandemic agreement, I will be advising countries to not sign. Don't sign it. There's no point. So that essentially will be my advice.
Yeah, so basically, similar to what you said earlier, that the PABs will be the deal breaker for the discussions. In the chat, there were also some questions regarding how can, and I know you've already alluded to this earlier, but it might be better if we can like expound more on how civil society and communities can engage in the pandemic accord, because right now it seems that it's very international. It's very like far from people directly working on the grassroots. So maybe you can like link those up a bit more.
Yeah. So I don't know if folks knew, but Africa Group in particular had a fracture in February. So there were some African countries that kind of went against the common African position. I think civil society in these countries in particular can play a really big role in terms of making sure negotiators, and these negotiators were not just going against African position, but they were going against some of the other global South country positions, right? And the global South, we cannot be fractured, because the EU and the US are going to be rubbing their hands and going, yes, these people are fractured, So we cannot, as the Global South, be fractured. So one of the things that we need to do is, and I know who these countries are, I'm not going to say in this webinar, but that's something that we can potentially do, is identify the countries that kind of turned, and start advocating at the national level, because these are, while there are some Geneva-based diplomats, they get their instruction from capital. So that's your Minister of Health, your, and if the negotiators are behaving in a way that is causing fracture, we need to be able to settle that at the national level. So I think that's one way to be
I
involved.
think the countries are known. The AU chairman issued a statement like that. So the countries, they know themselves.
Yeah, I don't agree with that statement. I think so, I think there are some, and please raise your hand if you want to speak as well. But I do think that, some countries, they came out in a newspaper, but there's the AU chairman didn't make, I would know because I worked for Africa CDC, but there was no scolding, essentially public scolding of negotiators who did turn. But there's certainly more that civil society can do to kind of sort and put pressure on people to keep to the common African position and keep to Global South positions, because we can't be seen as fractured.
So definitely global solidarity, and also making sure that there's some form of accountability also with the negotiators. So now we go to the people who have raised their hands. So we can go to Lizzie first, and then Olive.
Great, thank you. Mine is just focusing more, Fifa, on the financing. And I needed you to just help me understand one thing. So ENASO has been at the forefront in these discussions, especially we took the opportunity when there was a slight window of opportunity for CSOs to comment. So we did that virtually during the pandemic accord negotiations. But in terms of the financing, I was a bit unsure of what that meant, because there's a pandemic fund already that has been set up and fully running with finances, right? We have the global fund that has put up structures for the 3 diseases, and it's been working in one way or another. But then we're talking about setting up the mechanism for the pandemic treaty. And that's another, literally just going around to knock doors and asking for funding again. I was a bit confused. Why do we need to set that up when we already have the pandemic fund fully up and running and already being financed? It just felt like we are starting something from scratch, and yet there are already mechanisms and structures in place that can work with the pandemic treaty if it goes through. Thank you.
That's a good question. And the reason why it matters is because the pandemic fund is a World Bank mechanism. And if you know the history of World Bank and financing mechanisms, they can shut down financing mechanisms whenever they want. It is not sustainable. So there's some key things that you want in a pandemic financing mechanism. You want something that's sustainable, something that it has political, something that kind of is established, right? And there's essentially a good governance mechanism around it. So the concerns that countries had, so there are 3 African countries, I think, at the World Bank Pandemic Fund. I think it's Rwanda, it's Senegal, and one more. First of all, those countries don't represent the whole continent. So, and of course, I speak from knowing what the Africa Group discussions are. The Africa Group was against the pandemic fund being the fund, because the governance is not sufficiently accountable to African member states. The way I understand it, the countries that are there don't often speak. So, how do you get African interest in? With, of course, you've got civil society, but there's an issue about governance here, and I totally understand the issue on fragmentation of funds and money, because even at WHO, so it would be a WHO fund, right? But the benefit of having a WHO fund is it's always there. But of course, Global North the Global North arguments about not having a new fund, of course, is that they don't want to fragment their money, which from a donor perspective, I get it. But let's ask the basic question of, is the pandemic fund always going to be there? Considering World Bank's track record with their funds, which, sometimes are just closed with a change of leadership, right? So it's about that, and the ability to donate into that. And it's a WHO treaty, and the pandemic fund is a World Bank mechanism. So there's a little bit of that, the legalities behind that is concerning as well.
Thank you, FIFA. And since we're quite running out of time, I'd like to give the last question to Olive.
Thank you so much, both RJ and FIFA and everyone else that has been in the call. Mine are two quick questions. One is taking into consideration Rachel's presentation, where she introduced around Copper CE and the work that they are doing at country level, which is more around making sure resources, information, and that communities are more literate around pandemics, and they are able to influence decisions or policies related to pandemics. And we know that the Pandemic Accord is an instrument that, if agreed to, will be implemented at country level. I just wanted, FIFA, if you could just elaborate some opportunities you think that the Copper CE partners are able to take on, practical examples of who they should be discussing this information with, and what type of other resources exist out there, if you have. And then secondly, I wanted to also ask, we know that at global level, regional level, there are platforms that are engaged in the Pandemic Accord discussions. How do we, what structures exist that can be linked to these country implementers, so that there's that information coming down to the country level? And then also through the CE, there's information on what are the priorities going up to the global level. If you can just elaborate on that. Thank you so much.
Thanks so much, Olive. So in terms of what the community engagement can happen on this, there's so many of the parts of the text as it stands that will affect communities in quite a material way. One of them is in the health workforce section, which talks about equal remuneration based on gender. Although I think some African countries didn't like the word gender, so I wonder if it's been changed just to female. But that's one of the things that can really be tackled, both from the gender perspective, because I was making the case, look, if you've got a transgender nurse, you of course want them to be remunerated at the same level as a cisgender nurse, right? But everybody was like, we don't acknowledge transgender people, blah, blah, blah. So it was very controversial and it's very irritating. But it was something that fair remuneration is something that can be advocated at the national level and say, look, this is what's going to be in the Pandemic Accord. You might as well prepare at the national level by ensuring fair remuneration already, and putting things in place to have fair remuneration in pandemics. And of course, we know that the majority of health systems are held up by women. So that is something that can be sorted. But there's so much, and I don't know if this webinar is the right place to sort of go through each of the provisions and how communities can be engaged on them. But even on something as technical as PABs, your access to those vaccines that might have been developed from pathogens from your country, that is something that communities can engage in as well, because it's their right to health. So I think messages for community engagement around all of the topics are possible. It just matters as to how we can wordsmith it and fit it for purpose for community engagement initiatives. I hope that helps answer it, Olive.
Yes, it does. Thank you so much. And probably, FIFA, what you could do is on the key issues, you could if you could summarize them, and then we could share with the country partners so that they can take those discussions, because we also know that not everyone has that information. So what are the key issues and who should they be talking to? And if they find themselves in these key decision-making places, you know, what are the key 3 things they should be pointing on? But then I also asked about the coordination. Probably that's something you can share even in a write-up later on. I know RJ is going to provide a report because of time. Yeah.
So just on
All right.
coordination, I think we're awaiting a contract from the Global Fund team, I think, on to develop a toolkit on sort of PPR and how to do it. So once that comes through, we'd be able to develop something for you guys, for sure.
Yeah, and we can also share the resource material afterwards. But yeah, I think everyone can agree that this was a very comprehensive discussion, but also there are a lot of things that needs to be discussed further. So I invite everyone to actually join us in our post webinar discussion that will happen in our community WhatsApp group. So kindly join. I'll be sharing the link later. But let's probably also thank Dr. Fifa Rahman for her very excellent discussion on the Pandemic Accord 101. So thank you, Fifa, for sharing us your insights with this topic. And
Everybody.
sorry,
My pleasure, and thanks everybody.
thank
Thank
you.
you,
And
Hi, Dr. FIFA.
and you can also see Fifa from the chat that there are
Hi,
so
Steve.
Thank you.
Thanks, everybody.
Thank you very much.
Thank you. And on this slide, you can see the evaluation form. So we invite you to also answer this evaluation form so that we can improve on the succeeding lesson sessions that we will have with you. And you can also follow social media channels of APCASO on Facebook and Instagram. So we usually post there the recording of the video as well as a summary of the discussion so that it's more distilled later on. And here's the link for the WhatsApp group. Probably you can start with answering this question. What is your key takeaway from the discussion after we end the call? And if there are also relevant articles or resource materials, you can also share them in that community WhatsApp group. And lastly, before we end, I'd like to share with you that the Copper Knowledge Hub is already available for everyone to view. So you can visit it at copper.apcaso.org. So you can also scan this and it will lead you to the Knowledge Hub. So it's we're still trying to improve it, but all of the resources will be shared in this website. All right. So if there are no more concerns, thank you so much for attending our webinar.
RJ, before you close up, I just wanted to say that there are some questions in the chat box. Probably it would be good if we could compile those questions because some of them have not been responded to. And then in the report, we will provide some responses at least for those that have asked questions and have not been responded to. Yeah.
Okay, got it, Olive. So we'll be saving the chat and then try to also forward them to FIFA if she still has some time. And alternatively, can also email her as she mentioned a while back. All right.
So you can still put the QR code for the evaluation on the screen for people to at least give feedback. I think it moved very fast.
Sorry. Yeah, so here's the evaluation form. So I'll just keep it there. For those who need to log off the call, you may already do so. And